format that we're going to follow for our senior capstone research presentations is that every student is going to get about 12 minutes to present their research, and then they're going to have about 3 minutes time following their presentation for Q&A. So please write down all your wonderful questions, and we want you to actually engage in this learning experience. So let's go ahead and give a round of applause to our 3 capstone students for this semester.
All right, so I have the privilege of introducing Sydney Stewart to you all. I do want to give credit where credit is due, though, and let you know that I did not have the honor of being her capstone advisor. That was Dr. Franklin. So we shout out Dr. Franklin for that. But Sydney is majoring in biology with a concentration in veterinarian medicine and minor in neuroscience. She is from Lakeland, Florida, and has been at SEU for 3.5 years, one of which she's been in my classroom. And upon graduation, she plans to pursue veterinary school.
Okay. Hi, everyone. My name is Sydney Stewart, and today I'm going to come over here, and I'm going to be sharing with you guys my research project, which is about a GLP-1 agonist for treatment of obesity in canines and felines. So, how many of you have a fat cat or dog at home? Probably everybody. So, as we can see, the prevalence of obesity within canines is over here. Overweight is 38.6 or 36.8% and 18.9, and then even more so over here with the felines. So we can see that it's overall a huge problem, and these numbers just continue to rise. So why does that matter? So the problems that come along with obesity, as you can see, it affects every single part of the body, every single organ system. The most important one, the most impactful one, is probably the cardiovascular system. It actually causes myocardial stiffening, which is basically just the stiffening of the heart, which obviously affects the blood flow to all of the rest of the organ systems. So, how are we treating that? So, currently we have non-pharmacological options. Client education, letting them know how much to feed, how to actually assess the amount of obesity within their pet, and then prescription diets, which tend to be a little bit more expensive to keep up with. So pharmacologically, we have nothing. We've done the non-pharmacological for years, and obviously it's not working, so now we have to come up with something different. That leads me to GLP-1. It stands for glucagon-like peptide 1. It's a naturally produced incretin hormone, that actually induces the incretin effect postprandial. So basically that just means that after you ingest glucose orally, that the incretin effect is released because of this peptide that actually binds to this receptor right here. So the role of GLP-1 in canines and felines is very similar to that of in humans. It goes and binds to the receptor and then actually increases satiety, which is basically just satisfaction after eating, feeling full. It actually increases the amount of food that's in your, or not the amount of food, the time that the food is in your stomach. So that is the gastric emptying that it delays, and it increases insulin secretion, which regulates blood glucose. Exendin 4 is an example of a GLP-1 receptor agonist. So it's actually a mimetic of the natural incretin hormone. It's a 39 amino acid synthetic peptide that's actually derived from the glia monster. And like I said, its incretin, or its effect is to bind to that receptor and then produce the incretin effect. So that leads me to my specific aim number 1, which basically is the lack of information that is on the GLP-1 agonist within canines and felines is so vast that I actually had to do a literature review and go through and manually research all of this information on Exendin 4 to see its safety effects and whether it would be good for a potential trial. So my hypothesis going into it was that there was going to be no known significant facts in mammals with Exendin 4. So this is the beginning. So GLP-1 response overall, they were both pharmacologically responsive and active within both canines and felines. It was found that in females it actually has more of an effect in regulating insulin control, but that does not have any effect on its ability to treat obesity in canines. So, pharmacokinetics and pharmacodynamics. So it's excreted through the kidneys. So after ingestion, it breaks down and then you pee it out. The mechanism of action, kind of like I touched on before, it just binds to that receptor and then induces incretin effect that way. The extended release formation is actually what we would use for the actual trial. So they use microspheres to actually encapsulate the medication that allows for degradation over time in the bloodstream. Absorption, again, because of the lack of information, is really not that documented, but because of the regulatory processes and metabolisms within mammals, it's assumed to be similar to that of in humans. So, adverse effects and contraindications of the medication is mild nausea, some vomiting, sometimes dehydration because of the vomiting. It was really found that a lot of the contraindications and side effects were actually due to the incretin effect of the actual medication, which is examined for. And it was not due to actual toxicity, but more of the actual side effects. So if you're vomiting, you're probably going to have a little bit of dehydration, and you're probably not going to feel so great if you have stomach or food sitting in your stomach for a longer amount of time. The pharmacologic interactions, the only thing that they really found was that any additional insulin or sulfonylureas, which also induces the incretin effect, that just increases the risk for hypoglycemia, which could then cause an issue at that point. So from that, all of my determinations was that it has a strong safety profile and that it could be used as a really strong therapeutic option for managing obesity in canines and felines. So that leads me to specific aim number 2, which is to actually develop the trial for putting this into actual use. The hypothesis going into this is that weekly subcutaneous exentin-4 injections will actually increase the amount of glycemic control and then overall decrease the weight in canines and felines. So this is my actual proposed methodology. So where are we going to get these canines and felines? So canines are going to be purpose-bred beagles, and then felines purpose-bred domestic short hairs. Beagles are the most docile and most used laboratory animals for canines, and then domestic short hairs represent the majority of the population of the United States. These are both going to be ICUT compliant. That is basically just the organization that oversees safety and well-being of laboratory animals. So this is the overall structure. So we want to also consider the fact that the hormones that are introduced in metabolism within the reproductive organs, so whether they're intact or altered, we want to introduce that aspect of it as well. So that's why we have so many groups here. Negative control group, positive control group, neither of those will get the exentin-4 medication. One of them will have exercise, just because we want to have that as kind of a comparative group. And then the actual treatment groups will be treatment group number 1, who will not receive any exercise, just the effects of the medication, and then treatment group number 2, which is hypothesized to have the best outcome with exercise and both medications. So how are we going to dose it? Exentin-4, when used, the extended release formulation, when used within humans, was a 2 milligram weekly dosage, subcutaneously, which for about 70 kilogram human is about 0.03 mg per kg. So, translating that to canines, since we don't have any safety considerations with canines specifically, I lowered that down just to kind of just to account for that, get a baseline. And then for felines, they actually have a higher drug retention rate, which means that the drug actually stays in their body for a little bit longer than it does in canines. So we want to account for that with the 0.01 mg per kg. Feeding protocols. This formula here is actually called the resting energy requirement for both dogs and cats. So when they come in, we're going to make sure that all of them have the energy that they need. Using those diets, we'll calculate it off of the body weight when they begin the trial. Exercise protocols, like I touched on before, the negative control group and treatment group 1 will not have any exercise, so that means just walking around their enclosure, going outside to go potty, pretty much nothing else. The positive control group and treatment group number 2 will have 1 hour of activity for canines and then 30 minutes of activity for felines, which is supported by the weight management veterinary research. For canines, we're going to have outside, they fetch, go do whatever they want to do. And then felines, obviously they can't be outside, so we're going to keep them indoors. Some structured activity. And then for those who are not so inclined to participate in those, then we're going to obviously put them on the treadmill protocol just to ensure that we have uniform exercise within those groups. The trial timeline and data collection. So each of these little ticks that you see here is when we're actually going to be collecting data within the trial. And right here is where it kind of shows. So baseline data would just be a full blood panel, full chemistry, making sure that there's no baseline underlying conditions. This DXA scan is a type of X-ray that actually allows for differentiation between fat mass, bone density, and then also muscle mass as well. So that kind of really allows us to differentiate between what is actually fat mass versus other things. And then also a quality of life assessment, just to see how that improves over the span of the trial. Monthly monitoring, so we'll reassess all the blood panels, make sure that there's no inflammatory markers that are changing, anything going on that way. Weekly, we want to get the weights to record their progress over the trial, and then also the extended for plasma concentrations, which can be done via a LISA assay, which is just manageable to purchase online. Just a couple drops of blood, and then it tells you that. Daily is document overall demeanor, activity level, fatigue, just how much they're eating, what they're looking like, making sure that they're looking okay. The anticipated outcomes of this trial would be that it would effectively decrease overall body weight in obese canines and felines, and that we actually want to use this for a baseline for more trials regarding commercial use for this medication, since the prevalence is so high and the need for it is so great. However, there are potential limitations with this. I did not account for any of the breed, age, energy level. There are tons of variables that can be further looked into. However, I was just trying to get a baseline just because of the lack of information on this subject. Future implications, kind of like I've touched on, we really want to make sure that it's safe overall and to establish that overall dosing for future research into this in commercial use. Any questions? Yes.
Do you have any concern, there are no long-term GLP-1 studies in humans even.
Right.
And in most cases, patients have to now, the standard has changed from the initial standing with GLP-1s from where it was used as a short-term weight loss thing to now probably a lifetime medication. Were there any concerns about that?
There wasn't. I did see a lot of research on the short-term GLP-1 like you were saying, but since we haven't had it for that long amount of time, there's no research even on the humans. So this would be more of just establishing if it even worked for that, potentially, if that makes sense. So instead of it being more of a long time, this would be a short term, and then based on future research after that, then we could determine whether or not it should be long term.
Yeah, I would imagine one of the other complications of it would be when you look at GLP-1s in humans, and I'm on them, so, it's very often, you spoke of nausea and vomiting, dehydration. It's extremely serious. Like most people have to start at a very low dose and force themselves to eat and drink during those times. Getting an animal to do that.
Right. Yes, ma'am.
would
So
be
that's why
difficult.
with the daily monitoring and everything, I want to make sure that they're obviously looking okay. Are they eating? Is there an additional medical intervention that we have to do? Put them on an appetite stimulant, something like that, to get them to eat. So just kind of going over everything. There's a lot that could additionally happen as well.
And just a personal opinion, do you think that that warrants it? Does the risk versus the benefit, is it worth it?
I think
If it
that,
worked, let's say it worked, right? Let's say
Right.
it worked the way you thought it would.
yes, I believe that this is kind of a long stretch because the overall issue is the overfeeding. So we are able to control the problem. However, obviously our efforts of trying to control that problem have not worked. So now this is where it's leading us, kind of. So I think that at the end of the day, no, the risks don't outweigh the reward, but it's kind of, we're already reaching, if that makes sense. Yes. Oh, hi.
Can you explain some of the physiological role of incretin, since you're doing an antagonist to the incretin?
Absolutely. Yes.
That might not be just for glycemic control, right? Like what would be the side effects since you're doing antagonistic effects?
Correct. Yes, ma'am. Let me go back to much further away than I thought. Okay, so this is kind of just the overall natural incretin effect of the GLP-1 hormone. So based on where the receptors are located, which in the brain, pancreas, intestines, stomach, all of those places, it actually has different effects. So, like I said, with the brain, it increases satiety, things like that. So, and then the insulin secretion goes up, and then actually resistance goes down to insulin, and then the energy consumption also increases. So all of these processes are being activated, like the metabolic processes are being activated. So more things are going to occur than just the fat loss, but that would obviously be the main thing. So any of the additional side effects would be monitored.
Yeah, but so based on literature review, what have you gathered as far as what would be the possible effect if you turn it off? Right, because that would be your goal. So actually,
Correct, yes. So the regulation, so insulin resistance obviously goes up with a higher fat mass. So in order to reduce that, we're trying to, I'm trying to get this kind of like in the bloodstream to reduce that. And thus insulin secretion goes up, blood glucose control goes up, which overall allows for fat deposition to be stored correctly. So that's the overall kind of goal of that, if I'm answering your question.
Thank you. Thank you.
That was interesting. I never really even contemplated it in animals. I've read so much on it in humans. So our next presenter is Trevor Doris. He is majoring in biology with a concentration in med sciences. He's from Palm Harbor, Florida, and has been at SEU for 3.5 years. While at SEU, he rocked it on the football team, which went to the playoffs this year. And upon graduation, he's going to be pursuing a degree in chiropractic medicine. Come on up, Trev.
So today I'll be presenting on examining asymmetry and power and endurance between injured and non-injured legs in college football players post ACL, MCL, and meniscus reconstruction using sensor technology. So from a show of hands, how many of you in here know someone that has torn their ACL? So as you can see, it's a very common type of injury. For the injury I will be focusing on is called the terrible triad injury. It's a multi-ligament injury that primarily involves a tear in the ACL, which is the anterior cruciate ligament, as you can see right here in the middle of the knee. There's also a tear in the medial meniscus and a tear in the MCL. This is an image of the left knee. So this right here is the inside of the left knee, and you can see the medial meniscus right here and the MCL right here. So my story, about 2 years ago, as Dr. Sawyer was saying, I tore my ACL, MCL, and lateral meniscus playing football here at Southeastern. It was a pretty gruesome contact injury, and throughout my recovery protocol and rehab process, I noticed challenges and like bumps in the road that definitely could have been preventable. And I just saw the interest and need for research in this topic, and I believe that the implementation of sensor technology could have prevented some of those challenges. So right here is just basically an ACL surgery recovery timeline, a baseline type of timeline. It primarily just focuses on getting the patient back to weight bearing And then as you can see in week 3, light cycling to all the way to week 26. And the primary focus is just to get that knee strength normalized and the patient's quality of life maximized. So this works for most people and it's successful for most people, but for college football players and athletes of this caliber, it's not personalized and goal-oriented enough to get that athlete back to return to sport as soon as possible and as efficient as possible. So like I was saying, there's a lot of major challenges with baseline return to sport protocol for college football players. So this is another timeline of the different types of phases. As you can see, in phase 1, it's basically just focusing on getting the athlete returning to walking as soon as possible. And in phase 2, as you can see, it's like weightlifting, but the primary focus is load on the injured leg. So it's really not focusing on bilateral symmetry, and it's more focused on just getting that injured knee back to normal strength. But I believe there needs to be an implementation of more focus of bilateral symmetry in that phase. And then for phase 3, the focus is just getting the athlete returning to running and cycling again. And in phase 4, as you can see, months 6 through 12, it's a very timeline-oriented type of return to sport where the physical therapist, just based off of how many months it's been, can basically clear the athlete, which shouldn't be the way it's done. So different types of challenges. There's the chances of re-injury, of course, in those specific ligaments. But there's also a motivation and progress evaluation issue because the athletes aren't seeing the step-by-step personal, I would say, process that they need to see in order to have motivation throughout the progress. Again, I would touch on bilateral asymmetry, and another issue is returning to the same level of play. So each level at college football, it's a very high level of sport, and returning to that level is very hard after a gruesome injury like this. So baseline RTS protocol is not very individualized, and it's a very, I would say, one-size-fits-all approach, and it's very subjective from certain physical therapists. So one physical therapist could be telling you one thing, while a different physical therapist could be telling you another. They also base on how the athlete or patient is feeling and whether they have inflammation or not, which are all good gauges, but shouldn't be the primary, I would say, gauge for progressing in the protocol. So this is where I see a need for the implementation of sensor technology. So for football injuries by body location, as you know, football is a contact sport and a lot of athletes get injured, but right here in the green, lower extremity injuries are almost 25% of all football injuries, and if you include the groin right here, then it's over 25% of football injuries are just in lower extremities. So why is there a need? There's a lot of stats about post-ACL reconstruction in athletes, and only 81% of athletes return to sport in general. And then 65% of them return to their pre-injury level, while only 55% return to competitive sports. But I wanted to touch on that last bullet point for the 55% returning to competitive sports. As I was saying before, each level that you increase, so from high school to college and from college to the pros, that percent significantly decreases. So there's not a lot of compiled data on the amount of secondary injuries post-reconstruction. You may be asking, what do you mean by secondary injuries? So secondary injuries I talk about are muscular injuries post-terrible triad reconstruction, so like an injury in your hamstring or your quad. And it's very consumeristic, so insurance policies only want to cover for so long. As I was saying before, the return to sport protocol is only so long, so a lot of people want to return to sport within 8 to 10 months. And a lot of these secondary injuries take place after they have completed their return to sport protocol. So sensor technology is used. I'm not really reinventing the wheel. All of these sensor technologies have been used and invented, but not all sensors have been used concordantly throughout the patient's return to sport protocol. And sensors should be used on both lower extremities, not just one leg, and not just all the focus on the injured leg, but it needs to be used on both legs to assess for bilateral asymmetries. So this is where I saw a need for a more holistic approach because the body recovers as a whole, and an injury of this caliber affects more than just the knee. So for my specific aims, my aim number 1 is to implement sensor technology to determine asymmetries in gait, blood flow, and power output to help determine weaknesses in specific muscle groups. My hypothesis is players who use sensor technology during recovery will show improved balance, endurance, and overall performance compared to those who do not use it, due to a more accurate detection of asymmetries and early intervention during rehab. The methodology for this aim, about 60 post-ACL, MCL, meniscus reconstruction college football players will be used in this methodology, but only 30 of them will be using the sensor technology throughout their return to sport protocol, and 30 of them will just be using the baseline return to sport protocol with physical therapy. So there's multiple different sensors that I would be implementing in my research. The first two are pressure sensing insoles and power sensors. Pressure sensing insoles measure real-time weight distribution and gait asymmetry and foot strength mechanics, also a couple other things that you can see up here. The power sensors are also known as IMUs, which stand for inertial measurement units, and they measure acceleration, angular rate, and orientation. But while the athlete is exercising in their rehab protocol, they can measure jump height, power output, and also force production. So another two types of sensor technology that will be used are blood flow restriction cuffs. Blood flow restriction cuffs measure muscular endurance and blood flow dynamics and bilateral asymmetries. So this is very essential in the earlier stages of rehab, because what blood flow restriction cuffs can also do, and I've used them in my earlier stages of rehab, it mimics increased muscle load, causing hypertrophy at an earlier stage. So basically what that does is it means that it's putting the weight of heavy weights on the injured leg without actually having the danger of the athlete lifting heavy at that earlier on in protocol. So oxygenation sensors also are called NIRS, which are near infrared spectrometry, and they measure local muscle oxygen saturation. So a lot of you may have seen this type of sensor technology before. It's the isokinetic dynamometer, or dynamometer, which is also known as the Biodex machine. It's the gold standard for return to sport protocol. And what you basically do is you're strapped in the seat and you're kicking as hard as you can back and forth with resistance. And it measures the max torque output in isolated muscle strength in your quadricep and your hamstring. So it provides an objective limb symmetry index value. But this is very essential in return to sport and should be used. I'm not saying it shouldn't, but it shouldn't be the end-all be-all whether the athlete is good enough to return back to football. So as I was saying before, it's very commonly used, and it definitely should be used, but it shouldn't just be the end-all be-all. Aim number 2 is to analyze the most common lower extremity injuries post-ACL, MCL, and meniscus reconstruction and implement a preventative training protocol. My hypothesis for this aim is by analyzing the frequency of specific injuries in affected muscle groups, emerging patterns will be evaluated and then be used to design better preventative strategies for returning to sport safely. So the methodology for this aim will be another group of 60 male college football players post-ACL, MCL, meniscus surgery that will be tested. And the reason I did this graph with not any information in it is because the research that I've completed has a lot of information on the athletes up to about 10 to 12 months. And as I was saying, because it's consumeristic and a lot of it's measuring the patient in the return to sport protocol. But a lot of these secondary injuries, as listed right here, the different types of muscle injuries, they don't really happen until the athlete normally has returned to sport. So that's why I did the duration of 6 to 24 months, because the athlete is still recovering with the injury that is this gruesome. An athlete is recovering up to 2 years later. So the different types of injuries, the most prominent one is the hamstring injury. And I've seen a lot of research saying that the hamstring injury is the most common, but it also depends on what type of graft you have received. There's multiple different types of grafts that the patient can receive in surgery. They can receive a hamstring graft, a quadricep graft, a patella tendon graft, an allograft, which I received, and it's from a different human using normally an Achilles tendon. But of course, if you use a quadricep graft or a hamstring graft, you're going to have more of a chance of injuring that specific muscle group. So for aim number 3 is to develop a more personalized protocol for returning to sport based off of the asymmetries and challenges in recovery for that specific patient. And my hypothesis is athletes following a personalized RTS program based on the sensor data will return to sport faster and with fewer re-injuries compared to those using a standard RTS protocol. So as you can see here, there's two different types of timelines. The one on the right I want to focus on first is right here, is basically what I was saying before. It's based off of duration into a very subjective approach from physical therapy. So in 0 to 2 weeks, all that the focus is on is how the athlete or patient is feeling and how much pain or swelling they're having, all the way up to returning to sport, versus a step-by-step personalized return to sport protocol, which is very goal-oriented, I think, which will help with the athlete's motivation. But it should be step-by-step as soon as the athlete is moving as soon as possible post-surgery, all the way up to the final steps of completing a series of position-specific exercises and drills while fatigued with no issues. So my predicted outcome, up top is an image of Nick Chubb. He tore his ACL, MCL, meniscus as well, along with the same timeline as me 2 years ago. And
Nope.
no? How do I get rid of this?
Postpone. Postpone restart.
Okay. So, good thing I didn't click yes. The predicted outcome, as I was saying, Nick Chubb, he tore the same ligaments as me about 2 years ago, and he returned to sport very fast, if some of you follow the NFL. But at the NFL level, of course, they have more money and more technology, so I believe these sensor technologies were implemented and used, but at the college level, it's not very relevant or used, and there's not a focus on these different types of sensor technologies. And yes, it will cost more money initially, but I think it will save money for college football programs in the long run because it will prevent injuries. So overall, my study proposes a broader, multifaceted treatment approach that yields lasting results in improved overall recovery. I would like to acknowledge God and my Lord and Savior Jesus Christ, my family and friends, my professors, and my teammates and coaches.
I remember getting a question in medical school about two important, into this at the end is how much more do you think this approach would cost? And then who's paying? So that's the big question.
Yes.
How much and who pays?
So I'm not exactly sure on how much it would cost, but I know it would be a good amount. But the biggest thing that I saw, a way to do it is I received physical therapy through Watson Clinic, so they already had an isokinetic dynamometer. So I think smaller college football programs and smaller schools could kind of have an affiliation with the physical therapy department, so then they could help save them both money in the long run. And then for schools with not enough finances, I would say, to provide sensor technology for all the athletes that are injured, even if they got like 1 or 2 sets of everything, I think it would help prevent injuries and surgeries in the long run, because you don't have to just use it for athletes that have already been injured, but you could use it as a preventable approach for injuries in the future in football. Yes.
So, you are suggesting for several different kinds of sensors, right?
Yes, ma'am.
The one that you kind of mentioned more is the infrared, right, the nurse?
Yes.
What are the types of radiation or used for these different sensors? Because if you put this all at the same time, what's going to happen to the patient?
Yeah, so that might be a hard part of doing this, because the nerves and the power output sensors are kind of, and the blood flow restriction cuffs are kind of strapped all around the leg. So that is a challenge, but they don't necessarily need to be used at literally the same time. But I mean like used throughout the rehab protocol and process. So maybe one day you're testing the muscle oxygenation, and another day you're using your blood flow restriction cuff. But a lot of times the sensors are used at like certain checkpoints, I would say, like at a 6 months checkpoint, or a lot of times at 8 months or 12 months, just to get the athlete cleared. So for me, for example, I didn't use a Biodex machine, the last sensor, until it was time for me to get cleared, and I was not exactly bilaterally symmetrical. So I had, in my left leg, which was my injured leg, I had a stronger quad, but in my right leg, my left leg, my hamstring was weaker than compared to my right. But by then, I'm already trying to return to sport, so it kind of raises my chances for injury. And if you did it before an earlier onset and protocol, then I could have been focusing on that more throughout my protocol.
You mean there are side effects though of having all these different sensors?
No, because I don't think any of, like you said with the radiation, none of them are very like aggressive in the radiation, like even the infrared, the type of infrared they're using I don't think is aggressive to the body, I would say. And then the rest of them, a lot of them are based off of pressure. So like a lot of the force production sensing sensor technology are based off of how much pressure you put into the insole. So that can't really affect the body at all.
Would you say athletes who have these injuries most likely already have cases of bilateral asymmetry, so implementing sensor technology would be good to help prevent injuries so they can assess their bilateral symmetry?
Yes, so I kind of, for my research, I had to pick like one specific area, I picked post-op, but I think even preventable rehab treatment could be used because a lot of athletes tear a ligament because they're primarily using that or are using all their weight on that specific leg. So yes, I definitely think implementation could be used not just post-surgery.
We have to move on to the next presentation, but if you would wait, you can wait until the end of the talks and ask questions. Natalie? We have some extra time. So at this time, what we're going to do is set up the posters for the next poster presentation, which starts exactly at 11 a.m. This is the marine biology poster research presentations. It's going to be right here in this room. So all of the presenters who are here, you're welcome to come and set up your posters. And we're going to take a break now as we get ready for the next presentation. Let's give a round of applause to our capstone presenter.